Okay, so now let's switch gears to the melanoma specific structures. All right, ready? So, melanoma specific. Now, there are 10 melanoma specific structures, and here they are. Why are they called melanoma specific? If you look at specificity, they're all up in the high 80–90% range, okay? With that goes a high odds ratio for melanoma. Now, a melanoma specific structure can be seen in a benign lesion, of course, but if you see one of these 10 structures, right, the odds that it's melanoma is much greater than it's a benign nevus, a benign lesion. So now let's go through the 10 melanoma-specific structures. So first is atypical network. What's the definition of atypical network? With the next series of slides, everything on the left-hand side is benign nevus. Everything on the right-hand side is melanoma. And it's a compare-contrast to show you what the differences are. So in a nevus, the network is considered typical, or it's considered regular, when there is minimal deviation in the color and thickness of the lines. So there is minimal variability in the network itself. It tends to be fairly consistent, and it tends to fade out at the periphery. A network that has increased variability in its thickness, in its color, in its being broken up, in its sharp demarcation, all of that becomes atypical. So you can already guess that the definition of atypical is relative. It's relative to what's happening within the rest of the lesion. So that's a typical network, and that too is a typical network because of the definition. There is limited variability in the color and the thickness of the lines, becomes typical. Here, this network looks different than this, looks different than this, looks different than this, looks different than this, becomes atypical network. And if you look at it, what's happening on the pathology level, so here's your reedy ridge pattern, here's your reedy ridge pattern, that's giving you a network, right? And we know that in superficial spreading melanoma, all of the initial pathology is occurring up in the network at the DE junction. So if the DE junction is being changed, it's going to disrupt the normal network that you see. So as the melanoma is growing on this reedy ridge, the reedy ridge is getting darker. It's getting wider. You're seeing differences in width of the network, right? So that's the explanation for why this increased variability occurs in melanoma. On a computer level, this was also looked at. So what they did is they fed the computer a bunch of benign lesions, a bunch of melanomas, actually nevine melanomas, and they were only interested in evaluating the network. And the computer actually was designed, or the algorithms were designed in such a way to actually pick out the lines of the network and the holes of the network. And what did they find? The same thing. In melanoma, there was increased variability in the thickness of the lines. There was increased variability in the hues of color within the lines, and the holes of the network were of different sizes. So that was kind of more, in this study showed the same thing that we are seeing on the clinical, with our clinical eye. Now, streaks, irregular streaks, again, consists of both pseudopods and radial streaming. So what's a regular streak? A regular streak is having streaks around the entire perimeter of a lesion, okay? And that really is seen in Spitz and Reed's nevi. If it's focally present at the periphery, then it becomes melanoma specific. That becomes the irregular streak. And again, just to remind you, that streaks encompasses both radial streaming and pseudopods, and they represent confluent junctional nests. It represents radial growth, the radial growth phase of a melanoma. And here's again the Spitz nevi proof of concept that it's the radial growth of this, in this case, the Spitz nevus. Okay, now there are two structures, which is the negative pigment network and the crystalline structure. And in the past, these two were thought to be the same thing. Okay, and so I'm going to show you that they are not the same. They actually are two different, represent two different structures, also histologically. So one, you now know, the negative network are your supragenous interconnecting hypopigmented lines around these hyperpigmented elongated globular structures. Only seen, negative network can be seen with both polarized light and with non-polarized. It doesn't matter what scope you use, you'll see this structure. Now, I'd shown you this lesion before. This is the melanoma with the negative networks that's present just focally here. Sometimes you can see something that looks like a negative network in congenital nevi. You can also see a negative network in Spitz nevi, okay? In congenital nevi, if you actually look closely enough, these are really globules. They're just bigger, right? And sometimes they're kind of coming together, called cobblestone globules. So if you really take a look closely at congenital nevi, you'll know that this is not really the elongated, curvilinear globular structures. But in Spitz nevi, you can see the exact same structures as in melanoma. So that's your negative network, and again, negative network. Now, it's interesting, there's a study that I think Van Stecker was sort of instrumental in getting done, where they actually looked at globules and in melanoma and in benign lesions. And what they found, actually what they commented on in their discussion was this one sentence, and it says, elongation was the most common characteristic of an irregular globule. In retrospect, what this actually is a negative network. Okay, so this elongated sort of negative network type process is very specific towards melanoma and obviously Spitz. So here's your negative network seen with both standard light dermoscopy and polarized dermoscopy. Now, crystalline can only be seen with polarized, and therefore you can immediately already say that there can't be the same structures. So only with polarized. So here, Spitz nevis with these little white lines in the center. Here, little white lines in the center. And this is a hypomelanotic to amelanotic melanoma with crystalline structures throughout. So again, crystalline structures, short white lines, often oriented orthogonal to each other, and they're due to altered collagen. And just to let you know a little bit about naming, anybody here from Australia still remaining, or did they leave? Nobody from Australia left. No, there's one back there. So it's interesting that I think the Australians are much more analytical, is my sense. The Americans, I think, are a little bit more metaphorical. But the way that this evolved is interesting, and it's a fun story to share. So the metaphorical end of the world, which I adhere to a little bit more, there was these little, actually a wax moth, okay, and these are actually the cocoons of a wax moth. And what was noted is that they are short white lines, and they're kind of oriented orthogonal to each other. And so the word initially developed was chrysalis. Now, there was a problem with that, which we didn't realize because we were not entomologists. That is, chrysalis actually belongs to a butterfly, and a butterfly has a pupa that doesn't look anything like this, right? And what this really is a moth, and a moth doesn't create a chrysalis, it creates a cocoon. So then we were faced with a dilemma. Should we call it the cocoon structure? That's silly, right? It doesn't sound right. So we were forced to abandon that term for another term called crystalline, and I'll get to that in a moment. Now, the analytical people say, you know what, you guys are absolutely drunk if you think that I can see this in a melanoma. It's like, I don't know what you're seeing. Leaf-like areas. Are you seeing a leaf in a basal cell? I don't know what you guys are on. So they are very, very strict. Yeah, say, no, you should call these shiny white lines, right? Bulbous blobs for your leaf-like structures. So very analytical. And for me, the metaphor carries with it a lot of extra baggage, which helps us to remember, it helps us to teach, it helps us to implement, and it allows our brain to absorb more variations of this process. When you're very analytical, you're stuck, right? If your white line all of a sudden becomes a little more wider in a bulbous area, right? All of a sudden it's no longer white, and you have to change the terminology. Whereas the metaphorical brain will say, I still accept that as a crystalline structure, all right? Okay, now, why did we change the word from chrysalis to crystalline? Is that when you look at a crystal, right, you are still seeing lines, right? The crystal is made out of lines. And depending on the way you shine the light in it, right, it will allow you to see different colors. And so now you will remember crystalline can be seen with polarized light only, not with non-polarized, and they're lines, yeah? So that one metaphor carries with it a lot of extra baggage, but helps you know what that is. So that's how naming occurs. So here is, again, that lesion that was between Spitz versus melanoma unknown, and you can see that there's a negative network up here, and then you see these crystalline lines here. And again, the melanoma with the crystalline structures. And again, I won't play this video again, but I played it at the start, which was to show that the crystalline can only be seen with polarized light. Now, complicate matters a little bit more about the crystalline structure. Now, collagen is linear. So depending upon how the light, how polarized light is interacting with it, you may see it or you may not. So it's something known as angular dependence. And so for you to know whether the crystalline structure, when you're looking at a lesion, is truly absent, requires you to rotate your polarized scope 180 degrees, right? Because this crystalline structure may come in and out of view depending upon how that polarized light is hitting the collagen bundles. So you can play with this if you actually look at a dermatofibroma. Dermatofibromas have the collagen, so you'll see the crystalline. Just take your scope, put it on a dermatofibroma. The next time you're in clinic, rotate it 180 degrees. And you'll see that these lines will change, okay? And that's sort of the idea of angular dependence. So before you say there's no crystalline structures, rotate your scope once to make sure. Now, the significance of crystalline structures was done in this study where we looked at almost a little over 11,000 lesions. And you can already predict, so anything that has an altered stroma is going to have the crystalline structure. So basal cell, almost 50% of them had the structures. Dermatofibroma, by definition, they're collagen, right? The stroma, so you're going to see it. Lichen planus like keratosis, again, there's altered collagen, so you'll see it there, and obviously a scar, right? So in scar tissue, you'll see the altered collagen as well. So here's a dermatofibroma with crystalline structures. Here is a basal cell carcinoma. Right now, here, for example, right, for me, it's still crystalline, but it's not a short white line anymore. So it's not just, again, that point. Here's lichen planus like keratosis, white lines, crystalline structures. Now, when we looked at the melanocytic end of the world, it was an interesting finding. In almost 10,000 dysplastic nevi, we only found one with the crystalline structure. We found no congenital nevi with crystalline. We found no blue nevi. We found 2 intradermal nevi that had it out of 182. Prospectively diagnosed Spitz, all 3 of our Spitz nevi had it. Out of our invasive melanomas, 16 out of 17 prospectively diagnosed invasive melanomas had it. And out of our in situ melanomas, none had the crystalline structure. And so, from a differential, if you have a melanocytic lesion, really your differential is cut down to either melanoma or Spitz. And in your non-melanocytic end, your differential is between really three things: dermatofibroma, basal cell, and lichen planus, like keratosis. Dermatofibroma is not a problem, right? Because you know that you're going to touch the lesion, you're going to squeeze it, so you're going to put this whole picture together, and you just weed out your dermatofibromas, they're gone. So in essence, you're left between basal cell versus lichen planus-like keratosis and lichen planus-like keratosis versus melanoma. And this is the bugaboo that we haven't yet solved, clinically or dermoscopically. So many of my biopsies that I think is a basal cell, rule out basal cell, will be LPLK. Some melanomas that I think are melanomas will be LPLKs. Confocal microscopy is the only way to move forward with these. But on the clinical and dermoscopic end, you will not be able to tell the difference between a basal cell carcinoma and lichen planus-like keratosis, by and large. Okay, then we also looked at our consecutively diagnosed melanomas over time. So it's a retrospective view. And in the retrospective view, what we found is that 41% of our invasive melanomas had the crystalline structure. Only 17% of our in situ melanomas had it. And in the melanoma, in the invasive melanomas, the ones with crystalline were thicker than the ones without, with a mean thickness with those that had crystalline of 0.68 versus those that did not, which was 0.43. The crystalline structure can be seen in all forms of melanoma, from pigmented, hypopigmented, amelanotic to melanoma metastases. Here's a heavily pigmented melanoma. Again, crystalline structures all over the place. And again, just showing you the short white orthogonal lines that create this structure. Here is a hypomelanotic melanoma. Again, the crystalline structures in here. And here's a completely amelanotic melanoma, and crystalline structures everywhere. And then this is a melanoma metastasis, and here's crystalline structures here. And again, if you play this video, you'll see again the concept that between toggling between polarized and non-polarized, polarized, non-polarized, non. So again, you can see this structure only with polarized light. Now, what is all of this mean to us? So we now know that melanoma interacts with its environment. It's interacting with the keratinocytes, it's interacting with the fibroblast, the stroma around, it's inducing angiogenesis, and it's all sort of this concert of abnormalities that's occurring that allows melanoma to grow. And it's also been found that in early melanoma, for melanoma to actually gain access to the deeper skin, it requires collagen. It has to grow on collagen to get there. And so there are collagen tracts that are created for the melanoma to get into the deeper dermis. And then once it has passed this superficial part of the skin, then the melanoma becomes liberated from the need to be associated with collagen and can metastasize, okay? So, so that has been shown. And the other thing that has been shown is that when this collagen remodeling is occurring in melanoma, that this is also inducing neoangiogenesis. So the two are occurring side by side together. So when you look at a melanoma with crystalline, you will often also see lots of irregular vessels. So here are these little white lines, and throughout the lesion are also irregular blood vessels. So they will go together, hand in hand. And in fact, when in our data set, when we looked at crystalline structures when they were present, 88% of the melanomas had vessels seen under dermoscopy, and if crystalline were absent, only 12% revealed vessels. So again, just showing that this altered collagen and this neovascular, this angiogenic process are occurring together. So that's the bottom line with this, is that in a melanocytic lesion, why it's melanoma specific, you now know, but you will not be able to differentiate from a Spitz just based on the presence of that structure. Next, we have atypical dots and globules. So a nevus or a typical dot are dots that are localized to the center of the lesion, or, if you now remember, situated on top of the network line. Those are your two benign flavors. Any other manifestation of dots becomes irregular, so not associated with a network and not localized just to the center of the lesion. So again, regular, centrally located, or overlying network lines. That's your regular dots. And in Van Stekker's study, they showed the same thing, that if you had dots overlying the network, it was a negative predictor of melanoma because it actually is associated with a nevus. And again, to remind you why, because nevi often will have these little nests sitting at the tips of the reedy ridges, and therefore you will see the dot on top of the network line. Any other way that you see dots becomes irregular. Okay, globules. Now you have the benign or the typical globules. You have three flavors. You have globules throughout of uniform size, shape, and color. You have globules only at the periphery, or globules located in the center with peripheral network. Any other manifestation of globules becomes atypical. So here are your regular globules again. Globules throughout the entire lesion, globules located in the center with peripheral network, and globules around the entire perimeter of the lesion, which is a growing nevus. Those are your three typical globules. In your peripheral globules pattern, so around the entire perimeter, 50% of enlarging nevi in a population at risk for melanoma. So we're really talking about patients that have the dysplastic nevus syndrome type of skin. That 50% of growing nevi in those individuals will manifest this peripheral globular pattern. Now, another little caveat, right, is that these peripheral globules actually come in two flavors. One is that you have a rim around the entire perimeter, and the other one is that they are tiered, one tier and another tier and another tier. It's almost as if you had one burst and then another burst and another burst, and they are sort of stacked up on each other. So these are called tiered globules, like tiers of a cake. And these usually just have one rim, but at most they'll be staggered, okay, like the Roman legions, yeah? So that's your staggered pattern seen in a growing nevus, and the tiered pattern is seen in spits. All right, so by and large, if you biopsy lesions like this, you'll come out as a run-of-the-mill spits, not an atypical spits, not just spits. So here's your peripheral globular pattern, the Roman legion type, and you can predict that what will happen, symmetric growth of this lesion, once and eventually it'll enter senescence somewhere between 1 and 4 years. Okay, that's what the period of time for these lesions to enter senescence. Then the globules disappear. And when you have tiered globules, now you're thinking spitzoid lesions. Now in this case, there's lots of other things going on. You have crystalline structures, you have blue-white veil, and this happens to be another lesion where the pathologist could not differentiate between spits versus melanoma. Now, irregular globules is everything else. Okay, so globules of different sizes, shapes, and colors, globules that are not symmetrically around the entire perimeter and not localized to the center. So irregular distribution then becomes an irregular globule. And basically in Van Stekker's study, they found the same thing, that your melanomas tended to have larger, irregular, multiple colored globules, and the peripheral rim of globules was actually, again, a negative predictor of melanoma because that's a predictor of a growing nevus, yeah? All right, then we have the irregular blotch. So, what's a regular blotch? The definition of a regular blotch is one blotch localized to the center of the lesion, one blotch in the center of the lesion obviously no other melanoma-specific structures. And an irregular blotch is off-center or multiple blotches within the lesion, okay? Now, I'm going to share with you another interesting story about this lesion here. So this happened about 3 years ago. I think it was 3 years ago. And Steve, who is sitting back there and is running the entire show here, and by the way, he's not a physician, he's not a clinician, right? He runs the media part, heard this lecture, and at some point ended up going into the exhibit hall and grabbed himself a dermatoscope. And he started looking at his own lesions. And he noticed this lesion, and he came up to me and he says, you know, based on your talk, I think I have a melanoma. And I said, because of this peripheral blotch. And so my first reaction was, no way, right? It's not. And the minute I looked at it, I said, you know, wow, yes, it is. And now, so the first dilemma that occurred was, okay, now I know it's a melanoma, and now I've made a pact with Steve because I made the diagnosis, right? And I'm here as a visitor, so I have a relationship, right? I've set up a relationship. Now, how can I not do something at this point? So fortunately, Dr. Martin was available, and I said, listen, Steve, meet Dr. Martin. You are now his patient. And so I got rid of my responsibility, and then this lesion was eventually removed and proved to be microinvasive melanoma. Do I have the path? Yes. And so here's the pathology of this microinvasive melanoma, and obviously completely cured. But the message here, right, which also for me was like a eureka moment, yeah? And the eureka moment was, you know, you don't have to be a physician to be able to diagnose melanoma. And we knew that from the ABCDs, right? We've been teaching ABCDs to the public for a long time. So the idea arose that, you know, in the right hands, could dermoscopy be used by non-physicians, non-clinicians, by people at increased risk for melanoma? And we started thinking, you know, who? Well, you know, we know dermatologists, GPs. I think two to three out of every 10 scopes sold in the United States now is to a GP. Plastics. We are doing studies that have now shown that medical students can improve their ability to look at skin and diagnose skin lesions if they're provided with a dermatoscope. Pathologists, when they're doing step sectioning, obviously translational researchers. So that part we kind of had been thinking about, but what we didn't think about was, could this be used by patients? And so Steve was the first one that made me aware that, yes, you know what, if you had the right person, you could actually train them to look for their own melanomas. So with that, we had a few patients that actually found their own melanomas. One of them is Steve, so he's in this study on this small case series that we put together. And this idea is taking hold lots of places, and there are now multiple companies, okay? None of them that I'm involved in, unfortunately, but anyhow, multiple companies that are creating apps and technology to be sold not to you, to be sold to the public with instructions on how to use and you know, when to see a doc, et cetera, et cetera. So, and again, there's at least 4 companies that I'm aware of that are working on this project as we speak. So I predict that within the next 5 years, there will be dermatoscopes available at the pharmacy for the public to buy. Okay, we talked about the blotch and lamella story. So lamella is just the pigment in the stratum corneum, and the blotch is throughout all layers. And this is where it came. Okay, so here's the peripheral blotch. So by definition, you're saying, oh, it's not central, so therefore it has to be, you have to be thinking melanoma. But again, if it's a lamella, then it's meaningless. So here, all you have to do is tape strip it, and if you do that, you will see that there is actually no blotch. It's just melanin, and all you see is network, and therefore this is just a network and nothing else. So you don't have to put atypical blotch in there as a melanoma-specific structure, and this is a benign lesion. Okay, next is your blue-white veil over raised area. Now, can you see a blue-white veil in a nevus. You know, you can, if you want to be very strict about it, but I kind of consider this more of a very light bluish white hue, okay? When we talk about a blue-white veil, we're talking about in-your-face blue-white. Not like where you're saying, oh, is it blue-white? Let me change the angle. Okay, I think I see a little bit here. It's not that. It's like very conspicuous blue-white. That's what we're talking about. And that's your deep melanin and your compact orthokeratosis. The only benign lesion that can give you a blue-white veil is a blue nevus, but it'll be homogeneous throughout the entire lesion. So blue-white veil throughout the entire lesion. Now, one caveat is that if you look at a blue nevus with polarized light, you may actually see different hues of blue because, again, you're seeing the different depths of melanin, okay? So with standard dermoscopy, it's very easy. Blue nevus, homogeneous blue, right? With polarized, you have to learn to accept a little bit of this fluctuation in the hues. But again, the true atypical blue-white veil is very conspicuous, irregular blue-white veil, and that's your melanoma-specific structure. And again, deep melanin, melanocytes, and compact orthokeratosis. We already showed this video, I won't show it again. That shows that you can actually tease apart what you're going to see under pathology. So if you see the blue-white veil with standard dermoscopy and it disappears with polarized, you can already predict the lesion has orthokeratosis, right? Now, why is that important? We don't know that yet, but we do know that for whatever reason, melanoma often has orthokeratosis. Benign nevi don't. Now, the theory is, or the thought is, that the melanocytes are interacting with the keratinocytes, and they're altering the function of the keratinocyte as well. And so the keratinocyte, when it gets to the stratum corneum level, is not it's not normal. There's something abnormal about it, and it's sticking together and giving you this compact orthokeratosis. And there are people that are starting to look at this orthokeratotic component in melanoma. They haven't yet figured out what is the signal that's abnormal. And this is a negative study, but just to give you an idea that people are looking at even the orthokeratotic component in melanoma. Okay, now you have regression structures. Now blue-white veil over flat area, peppering, and scar-like areas. Now, in nevi, you can have small areas of regression. And small is defined as less than 10% of the lesion surface. By and large, it consists of peppering. It usually does not consist of scar-like depigmentation. Usually consists only of peppering. In melanoma, that is usually more than 50% of the lesion. You will see this peppering and blue-white structure. Here you only see a little bit right in here, this peppering, okay? And this came out of a study looking at regression in nevi and melanoma, and what they found is that if the regression encompassed less than 10% of the surface area, that it was really, that none of those turned out to be melanoma. If it was more than 50%, almost all of them were melanoma. And in between, you had to use other features to help you decide, okay? But those were the rules that came out of the regression part of the study. Okay, atypical vascular structures. So you now know that the only typical vascular structure is your comma vessel. Any other vascular structure is considered atypical and becomes melanoma specific. And we talked about the issue of compression. So the best way to see the vascular morphology is to use polarized non-contact dermoscopy. And what are the melanoma specific vessels? So again, this was the highlight article if you wanted to look at the details of all the vessels. But the synopsis is as follows. Milky red areas, meaning multiple shades of pink, which represents an increased vascular volume within the lesion, was one of the features. So here are multiple shades of pink. Dotted vessels. So here's a lesion on the lower leg of a nurse of ours. And this is the lesion with standard dermoscopy. And here's the same lesion with polarized. Okay? Notice nothing you can see. And all of a sudden you see dotted vessels. There's actually a linear vessel here as well. And what else? What are these white structures here? Crystalline. But they're not short white lines. But we know that they're still crystalline, yeah, because you're only seeing them with polarized light. Red globules, again, that's the neoangiogenic process around tumor islands. That's a bad sign. Then you have your linear irregular vessels, now termed under one called serpentine vessels. Okay? So, you can have these hairpin vessels, and hairpin vessels usually means a keratinizing tumor. And it usually seen either in seborrheic keratosis or in keratoacanthoma. Those are the two places where you see these hairpin vessels. Hairpin vessels can sometimes be seen in melanoma as well. If you just looked at this one here, you kind of say, okay, there's a hairpin here. But there's a difference between the hairpin in a melanoma and a keratinizing tumor, and that is that in a keratinizing tumor, the hairpin is surrounded by a white halo, and that's your keratin. Yellow to white halo. In a melanoma, it will be sitting in a pink sponge. So it's like a sponge full of blood, and you're seeing the blood vessel in it. So in a pink background, it becomes melanoma specific. In a white background, it is a keratinizing tumor. But anyway, so here are your serpentine vessels in a melanoma. And here again is the amelanotic melanoma arising of dysplastic nevus, the linear irregular vessels. If you can't see them, let me highlight those for you here, and hopefully you can see them all within this nodule. Then you have corkscrew or tortuous vessels, and those are seen in three places: melanoma metastases, nodular melanoma, and desmoplastic melanoma. So here, that's your coiled corkscrew vessel in a desmoplastic melanoma, in this case 5.6 millimeters. Here, this is the ankle, here's the foot. Patient had a melanoma here, here's a papule, here's a papule, here's a papule. There's actually a couple more up here. This is the clinical close-up of that papule, and here are your tortuous corkscrew vessels, melanoma metastasis. And then probably the most predictive of melanoma is what's known as the polymorphous pattern, which consists of dotted vessels and, again, this is now called serpentine, so linear irregular or serpentine vessels, so dotted and serpentine vessels. The combination is the most predictive of melanoma. So here's a patient that comes in for screening and has this little red patch that actually clinically I was thinking basal cell carcinoma, right? Superficial basal cell. And I wanted to see arborizing vessels, some shiny white areas, crystalline kind of that I would normally see in a basal. And what did this lesion reveal? This. And what it has are dotted vessels and linear vessels. So this combination, I knew that this is not basal cell. And so this is your pure amelanotic melanoma, right? So this combination of dotted and linear or serpentine vessels. And then your last melanoma-specific structure is your peripheral tan structureless areas. Now, again, remember, homogeneous blotch is hyperpigmented. Structureless, we're talking about hypopigmented but not depigmented. So that's a blotch, that's structureless, that's regression. So we're talking about hypopigmented but not depigmented within the lesion, okay? And so the significance of this structure is that if this tan structureless area is present at the periphery of a melanocytic lesion, it is suggestive of melanoma. So if it's within the center, then it's more suggestive of a benign process. And if it's towards the periphery of the lesion, it's more indicative of a melanoma. So tan peripheral structures. What does it correspond to? It corresponds to flattening of the D junction, okay, and pagetoid cells. Obviously, you need to have something to define the melanoma, right? So pagetoid spread is sort of not, if it's melanoma, you're going to see the pagetoid spread. So anyhow, So it's flattening of the DE junction. And so now you can already see, if there was a normal DE junction, you would see a network. If the normal DE junction is obliterated, it becomes structureless. And so structureless tan is more suggestive of melanoma. So structureless in the center, seen in nevi, structureless at the periphery, seen in melanoma. This also has a negative network, so there are other things there as well, but it has that peripheral tan structureless area. Now, we did a study looking at slow-growing melanomas, and if these are melanomas that were not suspected to be melanomas but were followed over time and then eventually were removed and it was proved to be melanoma, but another story. And what was noted is that these lesions, that one of the very common things that occurred is that the network, parts of the network got lost and were replaced with tan structureless areas. And so you now can already see why that is, yeah? So here's one that was followed over 10 years. The entire thing is an in situ melanoma, by the way. But notice all of this network here being replaced with structureless, yeah? And it's because this DE junction is being remodeled and is being obliterated because of the melanoma. So it's being replaced, and all you're seeing is the tan pigment. So those are your 10 melanoma-specific structures, and if you have a melanocytic lesion anywhere on your skin surface that manifests one of these 10 structures, you have to be thinking melanoma. So that includes on the face and includes on the palms and soles. But then, in addition, right, you have facial and palms and soles that have additional criteria. So on the palms and soles, you have the parallel pattern. And again, that's due to the dermatoglyphics. That's why you get the fingerprint structure. And the ridge is where the eccrine openings open up to. So your furrow is the valley is in between, then you have the ridge, and then you have another valley. And there's the gland opening up. And so if you dropped a little bit of ink, fountain pen ink, you could actually see the ink in the furrows. And why that's so important is that melanoma likes to grow around the ridge, the reedy ridge associated with the ridge, and nevi like to grow on the reedy ridge associated with the furrow. So therefore, you see in a benign lesion, you'll see the pigment in the furrows, and in melanoma, you will see it on the ridge. And the way that these get evaluated is as follows. This is the algorithm, which is a little bit different than the rest of the algorithm we're talking about. So on an acquired lesion on the palms and soles, if anywhere within this lesion you see a ridge pattern, you have to biopsy. You have to rule out melanoma. If it does not have a ridge pattern anywhere within the lesion, well, here's an example of ridge in a melanoma. If it doesn't have a ridge pattern, then you look for benign patterns, and those are your parallel furrow, lattice, and fibrillar pattern. So here's your fibrillar pattern, furrow pattern, and lattice-like pattern. Lattice is that the pigment is in the furrows, and then there's cross striations going over the ridge, okay? There are variants that we don't have time to go into, but those are your three sort of main benign patterns. If it has that, you basically reassure the patient all is done. Here you're, in a nutshell, your variants of your benign patterns: parallel furrow, dotted parallel furrow, double line furrow. It's still in the furrow, this pigment, but it's almost like a railroad track, and double dotted line furrow. But they're all still furrow, okay? Now, if it doesn't have a ridge and it doesn't have one of the benign patterns, then you're left with all other nevi, and there you are left with dictating what to do based on size. So if it had any other pattern, if it's less than, let's say, a centimeter, then you can monitor. So it's not like you say, okay, go home, leave it. You monitor for at least a year to make sure it's that's stable over time. If it's greater than a centimeter, and especially if it's in an older person, then you want to seriously consider a biopsy. So here's a lesion greater than a centimeter, and dermoscopically it does not have one of the benign patterns. It's not fibrillar, it's not furrow, and it's not lattice. and therefore dictated by size. And then this is a melanoma, a melanoma that is in situ arising in a nevus. And then on the face, you have the pseudonetwork pattern. And again, that has to do all with pigmentation around the ostia, so asymmetric pigmentation around the osteal openings, irregular pigmentation in the intervening skin that creates multiple structures that you have to get to know when you evaluate facial lesions, including granularity, grayish follicular openings, rhomboidal structures, polygonal lines creating zigzag patterns and blotches. And there's also these structures called isobars, which are circles within a circle, okay? Again, beyond the scope of this time allotted to go into more detail about this. But this is what I want to leave you with, is that the way facial lesions are evaluated is also a little bit different. And that is that any acquired lesion on the face, if it has any of the 10 melanoma-specific structures we talked about, then it's melanoma. If it does not, right, so there are no melanoma-specific structures, now what you do, and it has a pseudonetwork pattern, now what you do is you look for features that can nail the diagnosis. Does it have features that tells you it's a basal cell? Does it have features that tells you it's a lentigo, a seborrheic keratosis, or a hemangioma? And then you manage appropriately. If you have nothing, okay, you're left with either monitoring, but if you monitor, you have to monitor for at least 12 months. Because if it's lentigo malignant, it's going to change very, very slowly, right? Otherwise, it's biopsy. But I can tell you that there's a study that will be published any day now that's showing you that these lesions, confocal works great, and that monitoring is really not necessary because the confocal will tell you if it's malignant or not. And then lastly is your mucosal, which is a completely different realm in terms of morphology. There are benign patterns, and the structures that we see on mucosal surfaces consist of rings or half a ring, which is called a fish scale pattern. So ring and half a ring. And then you have lines that can be long and hypha-like or zigzag in that pattern, but basically they consist of lines. You can have dots and homogeneous pigmentation. That's it. Those are your structures that you see on mucosal lesions. And in benign lesions, you tend to have only one pattern, one of those, so lines or fish scale or circles. And in melanoma, you'll have multiple patterns. With that said, this is still in its infancy. This was the study that we did to sort of try to get an answer to that. But all of the melanomas we had were all more on the advanced side. So what do early mucosal melanomas look like? We don't yet know, right? So take this with a grain of salt, but it's now out there that multi-component pattern, more melanoma. If it's one pattern with rings, fish scale, or lines, it's more indicative of a benign lesion. There are multiple, this is just a little ad for, there are now podcasts available for your iPhone. They're all free. You can download from either iTunes or YouTube or from the International Dermoscopy website. And every one of the melanoma-specific structures has its own podcast of between 5 and 10 minutes that goes into excruciatingly painful detail about each of those structures. And I also want to encourage you to look into, if you've enjoyed this so far, we haven't finished yet, and want to learn even more than what you have learned here so far, then we've actually now organized a course that's going to rotate every year through a different national park in the U.S. And that's why did we pick national parks? Because I haven't seen any. So I figured it's an opportunity for me to see some. So the first one is going to be the Grand Tetons and Yellowstone, and then we'll rotate through multiple other parks over the course of time.